Do you know Sarah Ho? Do you know Sarah Ho at Liverpool?
Yes, yes. Her wife. I mean his wife. I mean her husband
Jason.
Jason, yeah, was
Yeah.
my colleague.
He was the what do you call it? The one like
Consultant.
but we didn't meet him. So Sarah said usually only does rounds like Saturdays a week or something. So that day we were there.
It was
It was
over
like
weekend, is it?
Sunday late night we went to eat. Then she was admitted that night. And by Tuesday lunch she was discharged very fast, 48 hours.
By the next Monday, Tuesday should be another doctor see. Cause he doesn't do rounds on
Yeah.
weekdays.
So the name was like in the ward there's a screen.
Yeah, yeah.
The name was there. But I asked Sarah said it doesn't do rounds. So I'm not sure like what the name means.
I think he was rounding over the weekend, so it's under his name but the doctor's outside. But actually the ward is inside is different.
Hopefully she could go fast.
Yeah.
Hey, hi. Hello. Hello.
Hi,
Hey, hi, hi. Hello.
Hello. This is Jessica, my friend. Who's giving the other talk.
Hi. The screen did the screen
Maybe it'll be washed by then. I'm very unsure. She's a Morena shirt, so maybe I let her wear the Morena shirt to see you.
Me too.
If you go on Facebook, I'm going to post it right now.
You mean on the
Public page. The public page. Okay.
It's being young. I find somebody didn't know about this.
Over there.
That's
What is it?
this one new one.
Yes, I just found out also.
You just found out, okay.
Just pasted yesterday.
They never invite us.
You just pasted it on Thursday.
Just came out. Fresh from the oven.
Fresh, yeah, very fresh. I was also looking at it as I was.
I don't mind coming eh.
You take a photo of it or something?
I woke up this morning and then last night
Sorry.
so I open up the earlier today, like earlier than my usual time to see his kid. So I started the even earlier. It was like felt like that yesterday. It's not even really just morning, I woke up to do and then we walk past lunch. So in the end it's like on Saturdays I rarely have lunch because like it's just no time. And then
The kids
like by the time
at
we
home?
get off at 2, then I'll just
Yeah, she does a piano class later.
Oh.
Okay.
I thought, I know. I heard my grandson want to take up also. Considering
I think one start see it through lah. Otherwise must
see why people get interest.
as in need to want to start them must make sure that practice. Otherwise it will be a wide different.
Your life.
I see anything starting is very fun. After that it's very going around. So always 36 like my niece went through this. Some of them give up, some of them didn't give up. Depend on them. But it's a good learning. It's a good experience for them. So many stages, so many exams to pass. They don't learn piano.
Testing. Okay. Okay, good afternoon, everyone, and a warm welcome to our annual health talk organized by the Limapin Road Church of Christ. My name is Eunice, and I'm a member of the Limapin Road Church of Christ congregation. And on behalf of the organizing team, we thank you all for your attendance today, and thank you for those joining us online. So this is the program for today. Our first speaker will be Dr. Jessica Kong, who will be sharing on the topic Building Healthy Smiles, Essential Dental Care Tips for Toddlers and Parents, followed by a 10-minute Q&A session. And after that, we'll have a short break and then return at 3 o'clock for the second talk by Dr. Grace Le, who will be speaking on understanding fever and common pediatric conditions, and then subsequently a Q&A as well. So now to introduce our... Oh, hang on. So this is a Pigeonhole QR code that you can scan in order to submit any questions that you have, and we will be addressing them after each talk. So now to introduce our first speaker, Dr. Jessica Kong. Dr. Jessica is an MOH accredited pediatric dental specialist with a passion for creating positive dental experiences for children. She graduated from NUS in 2013 and discovered her love for pediatric dentistry while working at the Health Promotion Board and National Dental Centre Singapore. Later on, she pursued a master's in pediatric dentistry and honed her expertise as a pediatric dental consultant at a leading dental chain in Singapore. In mid-2024, she started her own practice, Just Kids Dental Clinic. Apart from her work, she's also a busy mother of two, and we really appreciate her taking the time to talk to us. So, let's see. Oops. Okay, so without further ado, I'd like to introduce Dr. Jessica Kong. Thank you.
Hello everyone. So, hello. Okay, my name is Jessica. I'm a pediatric dentist by training. So what that means is that compared to a general practitioner, I did 3 more years of a master's course, and that's why I'm a lot more in tune with seeing children in terms of the treatment that they need to get done, and I'm more familiar with it compared to a lot of other dental GPs. Naturally, so after 3 years of training, I hope that that's what I will achieve. So I am the main dentist at my own clinic called Just Kids Dental Clinic, which is along Upper East Coast Road. It's fairly new, but we only see kids, as the name implies, just kids. And I see many children who are in their infancy, toddlers, as well as primary school age kids. And these are mainly my patients. So a lot of patients come being very anxious, or it's their first dental visit. And I'm very familiar with seeing children that are like that, and recognize that it's very normal for children to be anxious. And that's how we try to shape their dental visits so that as they grow older, they are comfortable with seeing a dentist. Like how many of us are actually very worried whenever we have to see the dentist, right? So that's what I want to change. I want to make it a pleasant experience for all our kids. I want to make it easy for children to see dentists, and in fact something that they will look forward to whenever they come and see me. And in the long run, that actually plays a big part in good oral hygiene, because if children are not scared to seek routine prevention, cleaning and all that, you'll find that it reduces their risk of decay. And then even in the future, if we do need to do anything that's more complicated like fillings, they will be already very comfortable with the whole dental setting, and that in turn makes them more confident. They are not so worried whenever it comes to dental treatment and visiting a dentist. Okay, so how do I move to the... Okay, so this is my clinic. This is how it looks like inside, and then that's my picture of me and my son. So I just wanted to show you that it's a very nice kid-friendly environment, so that a lot of children, when they come, even if they are anxious, when they see the environment, they feel a bit better. There's also a small playground there, which helps them to take their mind off the fact that they are seeing a dentist. Yeah, so I just wanted to share a little bit about myself. Okay, so for today, the topics that I will be covering are these. I am focusing a little bit more on the younger age, right, the infants and the toddlers, because I feel that this is the age where a lot of people don't think that dental hygiene is important, or they don't think that dental care is important. So they tend to kind of like they tend not to take much effort at this point. But in fact, when they're young and when their teeth are first coming through, that's when dental hygiene and kind of establishing all these dental routines is the most important. It sets them off on a good path, so that even as such as they get more and more and more teeth coming through, brushing doesn't get more challenging. They are very comfortable with brushing. Hello, baby. Yeah, so I'll be focusing more on the infancy as well as the toddlers, and then I'll touch in a little bit on when adult teeth first come in, which is around the preschool 5, 6, 7 year old age, and then I can talk a little bit more about why dental treatment or dental visits are important at that point. So, okay, moving on. So this is about when teeth should come through and when. So there's a whole normal range where teeth come in. A lot of people think that the first tooth must or should come in by 6 months old, but the truth is that when teeth come in varies from child to child, depending on their genes, depending on their own development. So we cannot worry when we like see other babies who have got their first teeth out at 6 months old, and then we're like, oh, why my child doesn't have any teeth coming out now? Is this something we should worry about? So I just want to let you know and reassure you that teeth come in at different ages in different children. Some children have teeth at birth. Some children have teeth a few days after they are born. Some children have teeth only at 1 year old. So the variation and the range is so wide that you shouldn't panic if you find that your child isn't on the following the whatever guide you're looking at, or isn't the same as their peer who is the same age, because every child develops differently. So what you then need to look out for is actually these 3 things. One is the most important is actually symmetry. Whenever teeth come through, if you look at the middle of the face, you want the left and right side to kind of be mirror images of each other. So if you see that one tooth has come out and the other side is not coming out yet, okay, don't panic yet, wait a few months, because there is a little bit of difference in the timeline between left side and right side, though they may need to be symmetrical, but we can give a few months leeway. So if it's asymmetrical, then it's a little bit puzzling, then that may warrant a visit to see a dentist. What you don't really need to care about is actually sequence and timing, which I mentioned to you just now about how it doesn't mean that at 6 months you have to have this tooth, at 1 year you have to have this, so you don't really need that. Sequence is also not important. So people think that it must be this, then this, or top, then bottom, it doesn't matter. Generally, rule of thumb is from front, then it goes towards the back. But even if you see a jump in sequence, like maybe the first molar comes out but the canine is not out yet, that is also okay. So you don't have to worry about that, as long as the left side and the right side are fairly similar and mirror image of each other. So the only time that you should panic, or not really panic, but where you should actually seek dental consultation is if your child has no teeth, like 0 teeth by 18 months old. That's usually the cutoff. So if 18 months old, still no teeth, please visit a dentist to get it checked out. So how teeth come through when from the time there's no tooth at all to the point where you actually see a tooth coming through, it does take a very long time. So it takes 2 months. And a lot of times teeth come in maybe one at a time. Sometimes you may see that multiple teeth are coming in at once. So there's a lot of overlap in the period of discomfort, like teething discomfort. So you may find that from the time your child's first tooth comes out all the way to the time the last tooth comes out, it seems like never-ending teething pains. And sometimes that is the case. Whereas some children, you will find that you're very lucky in the sense that your child doesn't show any teething symptoms at all, and that's also okay. So you may have some children who are very affected when teeth come through, and then you may see that some children are not affected at all, and then that again varies from child to child depending on your own individual child. So it's a very long drawn process, and it's really part of how teeth comes through. So teething pains are very normal, and we just have to help our child tide through this difficult period, and you'll find that once the teeth cut through the gums, after around that 1 or 2 months, your child will be fine again until the next tooth comes in again. Then the teething, the drooling and all starts again. So for the first, I would say, 2 years of life, you may find that your baby is very cranky, and then you may find when is this going to end? It will end when your child has all 20 teeth coming in. So these are what the things are to expect whenever your child is teething. So normal things are things like drooling, which then causes rashes around the mouth. Your child may be more irritable, crying more. Sometimes you will find that they don't want to eat, even though they are quite good eaters, but you will find that they reject certain foods. They will only want softer foods. Or you may find that they are always biting, putting things in their mouths. So these are all very normal signs of teething, and what we would expect in a child that is teething. But what we shouldn't have, and I think a lot of people believe that teething does cause this, is diarrhea and fever. So some people, they'll see their child has got diarrhea, see that the child has got fever, and then we just owe it to the fact that, oh yeah, because new teeth are coming through, child is teething. But diarrhea, fever, these are not normal signs of teething, but they are commonly seen when a child is teething because they put lots of things in their mouths. So hands are dirty, toys are dirty, remote controls are dirty, but they like to put all these things in their mouths, especially so when they are teething. So you will find that they pick up more of these illnesses when they are sick, especially so if they go to infant care, for example, and then they put lots of things in their mouth. So if your child does have any of these, like has diarrhea, has fever, need to be treated properly, go see a doctor, and then they'll get it properly treated, rather than for you to just let it, like, owe it to teething and not have it properly treated. So I have some teething solutions that I would recommend. So in general, for daytime, if your child is very cranky, you can give them things to gnaw on. So personally, things like these chilled liquid teethers, you can pop them in the fridge and then get them quite cool so that they can gnaw on it. Something simple like washcloth, the same washcloth you use to wipe their face, you can wet it, tie a knot, and then you can freeze it, and then you can let them kind of gnaw on it as well. So that's quite comfortable for the gums. At the same time, it actually cleans the teeth too because it's like a cloth. So you can do that. Even things like fruits, like watermelon and mango, you can cut them into a wedge shape and then freeze them up, and then you'll find that that's actually quite good for them to gnaw on as well, especially during mealtime. You want to teach them how to self-feed, put things in their mouths, then you can consider these frozen fruits. Teething gels are what is quite commonly used by a lot of parents, but personally I wouldn't recommend them because teething gels do contain a lot of numbing medication inside, and sometimes so many teeth are coming out at once, and we just squeeze an arbitrary amount on our finger, not sure how much to apply also. Then we just squeeze on our finger, then we apply everywhere because we don't know which one it is that's causing them pain. And then it works for maybe about 10 minutes to 20 minutes, but then your child swallows a lot of this numbing cream. Then after that 10 to 20 minutes, you realize that, effect has worn off. Then you apply again. So then after a while, your child is actually ingesting a lot of this numbing medication, which is not measurable because you don't know how much you have applied and you don't know how often you've been applying. So if your child is very affected, particularly maybe at night, affecting your child's sleep, affecting your sleep as well, then my suggestion would be to give a dose of Panadol, the same dose that you will give if your child was having a fever. At least it has a more general effect, works for a good 6 hours, rather than for you to just keep applying numbing cream and not knowing how much you're applying. So numbing cream, this teething gel only for when you are really desperate, but otherwise in the daytime try to let them gnaw on different stuff, and then for nighttime Panadol more effective. Okay, so the next thing I wanted to talk about, and this is what I would say 50% of my patients do come to me for, is actually decay. Decay in baby teeth is not uncommon. Research has shown it affects about 50% of our children before they even enter primary school. So cavities are getting even more common nowadays, I think because of our diet. A lot of our foods that we have a lot of hidden sugars inside. Even things like formula milk as well, they do have a lot of sugars added inside as well. So a lot of children that I see, parents will be very surprised to hear that, my child has got decay. Then they'll say that, last time when I was younger, I didn't have any decay at all. But the truth is that our food has changed, our lifestyles have changed, we snack a lot more as well. So it is not uncommon to have cavities. And I think a common issue a common question that I get from a lot of people is, at the end of the day, they're still baby teeth. So why do we need to worry about decay on baby teeth? The reason why is because a lot of people have forgotten when their baby tooth has fallen out. Everybody thinks that baby teeth fall out at about 6 years old, 7 years old. That is not wrong, but it's the half truth. So the upper and lower front teeth do change. Later I'll talk about this a little bit more later as well. But the upper front teeth change about maybe 5 to 7. But the back teeth, which is where we most commonly see decay on, only change when your child is about 11 or 12. So for example, I see a child who's perhaps 3 or 4 years old, and then they come in with a decay on their back teeth. That back tooth is going to need to stay in the mouth for about 8 or 9 years more, which is a long time. 8 or 9 years old is more than the life your child has just lived, like almost triple the life your child has just lived. So it's a very long time to leave something untreated. And at the end of the day, what we want to prevent is your child getting pain, toothache. And that will be inevitable if, let's say, your child has got decay at 3 or 4 and you leave it untreated. Then eventually a toothache will come along, and we don't want our children to be experiencing pain, especially pain that could have been avoided. So what does a cavity look like? So on the left is actually just stock pictures, but actually on the right are my patient's pictures. So you can see how A cavity, also what we call decay, also scientifically what we call caries as well, is that picture that we can see on the left side, and this is how it progresses. So healthy teeth, you see it looks like a nice white shiny surface, and then what happens is that if teeth are not cleaned properly, and how we tell whether teeth are clean or not is if you look at the picture that's in the center, you can see that yellow dirt that's along the gum line. So that yellow dirt is what we call mature plaque. It means that the area hasn't been brushed well. Over time you get this very yellow sticky dirt that even with best efforts with brushing, most of the time at this point parents can see like, wow, my child's teeth are really dirty, then they try to brush, cannot brush away. How come cannot brush away? It's because this dirt is very old dirt and it has become very sticky, so this is professionally needs to be removed. Then once we remove it, you'll realize that the in the middle, that top picture and the bottom picture is actually the same teeth. It's just that one is after cleaning and one is before cleaning. So you can see before cleaning there's all this yellow dirt. And then after cleaning, you'll notice that at the areas with all the yellow dirt, there are all these white patches. So where that yellow dirt was at, it was actually sticking on the surface for a very long time and causing the underlying tooth to get very porous. So once it gets very porous, you see these little white lines underneath the yellow, and these white lines is what happens when the tooth becomes porous. So when a tooth becomes porous, it means that it's now weakened. And if let's say the yellow plaque had stayed there for an even longer time, you won't be seeing just these white spots. You'll see that these white spots have now developed into a hole. And that's what we will call a cavity. And once a hole forms, we have to fix it because it will become big fast, because things keep getting stuck inside. Every time you try to brush it, you can't really brush it very well because it's like a cave. So on the rightmost, you'll see that that's how a cavity that has started from between the teeth has now progressed and broken to the biting surface. So this is like what I mentioned to you, like it's a cave. Like whenever, like maybe now you know, okay, my child has a decay there. Then you say, can I not do anything and just keep brushing and keeping it clean? It's honestly very difficult to keep something like this clean, because when you eat things like biscuits, it just gets forced into that hole, and it's like a cave, it's a concavity. So even with your best efforts with brushing, you will not be able to get it very clean, and then you'll find that with time it will progress quite quickly. So what we want to do is really to not only come to the dentist when your child has got decay, you want to catch it at the early point. And I would say a good point to catch it will be even before this yellow dirt forms. But if your child has yellow dirt, then bring. If your child has decay, also bring, because it's never too late. It's never too late. It's better now than never. Okay? So what causes cavities? So cavities can be prevented, and I think what we commonly know causes cavities are sugar, and of course a combination of poor oral hygiene. So poor oral hygiene is very high up on the list. So with irregular brushing or maybe inefficient brushing, your child is not very cooperative, cannot brush well, then you'll find that with time the teeth just get dirtier and dirtier. And that's quite normal, because I mean it happens for everyone. Even as adults we have to brush our teeth. So it doesn't make it, there's no difference from adults and children with our teeth. We still also have to uphold the same kind of good oral hygiene or habits that we impose on ourselves, on our children. So poor oral hygiene is a big cause of cavities. Another one is diet. So when I talk about diet, is not only the things that we know like sweets and all, but even some hidden things, like some people think like biscuits, not so decay causing, they're actually very decay causing, even those that are salty. So later I'll show you some examples of what I mean by diet. And even frequent and prolonged consumptions of liquids containing sugar. I put a milk bottle there because that is like one of the top reasons why a lot of our children now get decay, because they are drinking a lot of milk from bottles. And it's not about the milk, neither is it about the fact that it's a bottle. It's the frequency as well as the prolonged consumption. So what I mean by frequency is maybe at night they wake up every 3 or 4 hourly to have milk feeds, and that's what a newborn does, and that's perfectly fine because your newborn doesn't have teeth. But it becomes an issue when your child is a toddler and they've now got a lot of teeth, but yet they're having feeding habits like a newborn does. And that's when you will find that their teeth develop decay quite quickly. So prolonged consumption is again like what I mentioned, you know, this kind of 3-4 hourly feeds are for newborns, not so much for older kids where they are eating solid food or should be eating solid foods just like an adult does, but yet they are very reliant on very frequent night feeds. Then you will find that their risk of decay then gets very much higher. Okay, so how do we prevent decay? So to prevent decay is to address the causes of decay. So what we want to do is to make sure that we protect the teeth by making sure that we remove the dirt well, and that will be through tooth brushing as well as through flossing. We can also use fluoride as well. So fluoride can be in our toothpastes. It can also be professionally applied whenever you go for your routine dental visits. And what this does is it helps to make the teeth strong. So fluoride is something that helps to stick onto the teeth and make the teeth stronger, so that even if there is decay, you'll find the decay doesn't progress as quickly, but it also helps to prevent against decay. There are alternatives to fluoride as well that are safer to swallow, but like for example hydroxyapatite toothpaste, but that's not something I will talk about in this talk. So other things is to watch your diet, and the last thing is to schedule your child's dental visits early, and then to keep to a very fixed routine in terms of their review. So we usually look 6 months, maybe 9 months, maybe annually, really depending on what we see when at the dental visit. So if your child has got a higher risk of decay, then the need for more routine visits gets higher. If your child's teeth are quite clean, then we can just do annual, good habits, diet is good, brushing is good, we look in the mouth, everything is quite clean, then it's just really annual visits, which is not too much to commit. It's like, we go see, like, for example, Dr. Grace, who's a pediatrician. I'm sure we bring our kids to see doctors a lot more than we actually bring our kids to see dentists. Okay, so I have a little picture that's on the left, and I just wanted to touch very briefly about what this is. So a lot of parents that I see bring their kids in for these black stains that are on the teeth. So this is just stains, they're not decay. There are many reasons for stains, but this is a very common stain that we see in children. So you'll see these little black dots, particularly along the gum line, and this is what we call chromogenic bacterial staining. So it's not decay, it's not harmful for the teeth. It may get worse, but it is generally an aesthetic problem. I can clean it off for you, but it will come back. And the reason why this happens in a lot of in children is because in their mouths they have this bacteria called chromogenic bacteria. It's just part of the normal microbiome in the mouth. So some children have it, some children don't, because the kind of bacteria as well as the kind of viruses we have in our mouths are all different, but a lot of children do have this chromogenic bacteria in the mouth. So if you have a diet that's very high in iron, for example, any multivitamins, iron supplements, or if your child is on formula milk, which is usually iron fortified, or eats a lot of broccoli or spinach, you'll find that these stains can come quite quickly. Even after we clean it off, it'll come back quite quickly. So this is something that I just wanted to touch because it is very common in our population. I see many children coming to me for this with parents believing that it is actually decay. But the story is, if you have these stains and you are worried, just bring in just to get it checked as well, to make sure that it's really not decay and it's really just stains. So I'm going to talk about what cleaning tools we can use in order to brush. So for oral hygiene, or getting your child used to anything being in the mouth, should start from the get-go. So even when your child is a newborn, you do want to instill some sort of oral hygiene regime in them, just so that they have a clean mouth, and also you want them to slowly get used to the feeling of something being in their mouths. So before any teeth come through, so for example, newborn age onwards, till maybe about 6 months, maybe even 1 year old, where they don't have teeth, you can continue using these tools, which is the one that's on the left is a silicone finger brush, and then the one on the right most is actually a silicone brush. So you'll find that the bristles are made from silicone. They're not nylon bristles like how our adult toothbrushes are. You can even use a wet gauze. You can wind it around your finger and just wipe the gums, wipe the cheeks, wipe the tongue. And this helps to remove the milk curds. It helps them to get used to the feeling of something being in their mouth, and it also helps to establish a dental routine. So you try to do everything in the same sequence every day, so that they know that, okay, after this is coming, after this is coming. Children like sequence and they like routine. So if they are very familiar with a fixed routine, you'll find that they will start to accept it a lot more, knowing that this is what is happening, every day. So once teeth come through, you have to transit over from all these silicone equipment over to a bristled toothbrush. So bristled toothbrushes are brushes where the bristles are very similar to our adult toothbrush bristles. You will be looking for something where the head of the toothbrush is about a 10-cent coin, so not too big, because if it's too big, you'll find that, especially once their back teeth come through, it's quite difficult to access the area where the space is a bit tight. So use a bristled toothbrush. What I look for whenever I buy toothbrushes is I look for a bristled toothbrush, head of the toothbrush about the size of a 10-cent coin. The bristles are uniform in height, and the bristles are dense. So you want to look for something that is like that. You don't need all the fancy stuff like rubber cups. You don't want it to go like up, down. You don't need to have like, now there's one that is in the shape of a paw print. Looks very cute, but not very effective. So you want to look for a very simple toothbrush. And then you will you will need to gradually introduce flossing, especially once you see more teeth coming through and they are touching. So side by side teeth touch, those are surfaces where flossing needs to get done. But our priority is always first brushing and then flossing. So if your child is very uncomfortable with brushing, then I would say don't stress yourself by trying to do flossing also. Get your brushing down pat first, and then once that is okay, then you can start introducing flossing. We try to aim for daily, but admittedly not all of us do that. Even I don't do daily flossing, but we try to do it as often as we can, aiming for minimum of maybe once every 3 to 4 days. So I would say 1 weekday, 1 weekend. And if you can get that in on top of good brushing, usually it's more than enough. So another thing that we can consider as well is toothpaste. So these are a few brands that do have enough fluoride. So whenever I buy toothpaste for my kids who are now old enough to spit, I will look for, the main thing is how much fluoride there is inside. So we want to look for a minimum of 1000 ppm fluoride. It's usually written on the packaging, the box itself, the tube itself. Sometimes just on the ingredient list you have to look for it. So we are looking for something that has at least 1000 ppm of fluoride. It can be more than that, but it shouldn't be less than that. So first look for fluoride content. The next thing you look out for is whatever flavor or the kind of paste or gel your child would like. So there are different kinds of flavors. There's like the gel consistency, there's the toothpaste consistency, so you decide which one your child prefers. There are those that kind of foam a lot more than others, so you also decide on that. And then of course how the toothpaste looks as well. So sometimes they have these cartoon characters that will motivate your child to use toothpaste more. So that is what you next look at, the appearance of it as well as the taste of it. The thing that you don't have to look at is actually the age that's written on the packaging. So the age is all over the place. You'll find that some of them that have got higher fluoride actually write a lower age group. Some of them that have got very low fluoride actually write a higher age group. So the age is really not important and not something that you should be looking at. So how much toothpaste do you use, and do you even use toothpaste at all? So in general, children who are less than 2, they are not good at spitting. Or if they do know how to spit, you'll find that just before you get them to spit, they will take a big gulp of whatever is in their mouth, and then they'll try to spit and nothing comes out. So that is very normal because they haven't learned how to spit out toothpaste yet. So less than 2 years old, they usually don't need any toothpaste at all. You just use a wet toothbrush. You don't even need to use those non-fluoride baby toothpastes, because the non-fluoride baby toothpastes, as the name implies, it doesn't have fluoride inside. So because it doesn't have fluoride inside, it doesn't have the intended protection that we want toothpaste to have, but it tastes nice. So sometimes you'll find that it in fact makes it harder to encourage your child to spit because it tastes very nice. So every time you brush, they swallow. And then eventually when they're older, around 3, and you're trying to get them to spit because you're like, okay, now you really need to use fluoride toothpaste because you're eating a lot of sweets and biscuits, they are still constantly swallowing all the time. So I prefer no toothpaste at all rather than to use a non-fluoride toothpaste. And sometimes the non-fluoride toothpaste can also make your brushing more challenging. You find you put your toothbrush in the mouth and your child treats the toothbrush like a lollipop because it tastes so nice. They suck, bite on it. And then you'll find now I can't see the teeth. My toothbrush can't move because my child is biting on it. So it's better to not use the non-fluoride toothpaste. The only times I would recommend using a non-fluoride toothpaste is if your child is much more cooperative with brushing because of the non-fluoride toothpaste. Like maybe they like the taste so much that they look forward to brushing all the time, but without it they don't want to brush teeth, then you can use a non-fluoride toothpaste. Or if you're actually in the process of training your child how to spit. So maybe you've been practicing and you're like, oh, okay, I think her spitting is more or less quite good already. I'm going to try. Then you can try a non-fluoride toothpaste, and then you'll realize that, oh, okay, my child, even with this nice sweet taste in the mouth, is able to spit well, doesn't swallow when I actually brush for her. Then you now know that, okay, after this non-fluoride toothpaste is done, I can now transit her over to a high fluoride toothpaste without any concerns that she is swallowing toothpaste. So 2 to 3 years old is when I would suggest training their ability to spit, and you can do that by after brushing, bring them to the toilet, give them a cup of water, let them practice their rinsing. Or you can even paste some stickers on your bathroom wall, give them a cup of water, ask them, can you spit at the stickers? And this teaches them how to hold the water in their mouth so they have got something to aim at. Okay. Once they are more than 3 years old, then you can use a pea-sized amount. A pea size is very small. So when you squeeze the toothpaste out from the tube, it's just maybe about 4 millimeters of toothpaste, and that's it. And we never ever need to use more than that. Even when they are very good at spitting, or even as adults, we never need to dispense, you see the advertisements, full length of the toothbrush is the toothpaste. We never need that. We always just need a pea size, and that's all. Okay, so I'm going to talk about the toothbrushing method. So what we want to do is we always want to do a scrubbing action left and right. We always want to angle the toothbrush towards the gums at a 45 degrees, and we want to make sure that the lips are not in the way. So for the top teeth, you want to push the lips up, and for the bottom teeth, you want to push the lips down. Rule of thumb is to always make sure that they go to bed with clean teeth, and that means that if your child has a habit of milk bottle before bed, like maybe you brush, then you milk, then you sleep, this is something that you can try to work on. When they are young, usually this is the pattern. But as they get older, they should be more awake after their milk and not really relying on the milk for sleep. Then you should then introduce the brushing after the milk rather than before. Okay, so these are different positions that you can position your child with when brushing, depending on how cooperative they are. The leftmost picture where this is my son is lying between my legs. This is actually the best way to brush. The reason why this is the best way is because you can see how I've got two hands available. One hand is to push the lip up, the other is to hold the toothbrush. In all the other positions, my other hand is behind him because I need to support him, I need to cradle him. So now I only have one hand, and my one hand is holding the toothbrush. So how to lift up the lip is very difficult, made even harder by the fact that now your child is also moving. So between your legs like this is the best because you'll find that you have both hands available. His head, his back is supported by the ground, so you don't have to worry he'll fall down. And you will find that now you can see directly what you are doing, direct vision into the mouth. When you can see what you are doing, you can brush better also. You can brush faster also because you're not trying to see, am I at the right place? Am I not at the right place? So that, okay? Be patient, be fun, and be consistent. So consistency is key. If on days where they are very upset, they cry, and then you say, okay, today don't need to brush teeth, they will not one day stop crying and say, now you can brush my teeth. It will always be, I'm going to cry my way out of brushing every single day, and you'll find that after a while it'll take a toll on everyone, and of course take a toll on the teeth as well. Okay, so I'm going to show you a video on toothbrushing technique. So this is how I brush for my daughter. So you can see this, you see how I lift up the lip? Okay, it's a bit laggy, sorry. Again. Okay, so it's still a bit lagging, but you can see the action that I'm doing is a left and right scrubbing action, and with my left hand I'm actually lifting the lip away. A lot of my toothbrush is actually on the gum, so I'm not just brushing the teeth only, but I'm actually brushing half of the gum. My toothbrush is contacting. Half of my toothbrush is contacting the gums, and the other half is contacting the teeth. And what you do is you make a very gentle left and right motion. It's very different from what we learned last time in primary school, where we have to do this like downward stroking or outward stroking action. What we do is you just hold it at the gum line and do a little like left and right jiggle. Okay, so I wanted to show you all flossing technique also, but we can show flossing technique also. Thank you. Okay, so this one shows flossing, but also a bit laggy. Okay lah, never mind lah, skip lah. It's okay, you can skip. Okay, so let's talk a little bit about diet. So these are a lot of things that kids eat that a lot of people don't think are actually very decay causing. So I just wanted to go through each one of it and why it actually is. Okay, some people know that they are decay causing, but some of them are quite hidden sugars, right? That's what I would call. So for example, the goldfish, right? A savory, not sweet. This is very decay causing because you will find that it's very sticky. So generally, if you find that you eat a biscuit and as an adult you need to use your tongue to clear it away, or you need to use your fingernail to dig it away, these are generally sticky foods, and children don't do that. So if they eat something and it's stuck on their teeth, they just leave it there stuck for the whole day. And if your child is very bad at brushing or very uncooperative during brushing, then you try to brush, you cannot brush well, then you'll find that the biscuit can stick there for almost 48 hours, and that's usually how decay starts. So Oreos are big decay causing. If you find that your child eats Oreos, at night you try to brush your teeth, you'll realize like, wow, how come I scrub and still cannot get these black stains off because they're just that sticky and they're that difficult to take away. So I'm not saying your child cannot eat all these biscuits, but the best time to eat biscuits is actually during meal time. So breakfast, lunch, dinner, and coupled with a lot of drinks, coupled with a lot of other foods, and you'll find that the other foods can pick up all these biscuits from the grooves much better. When you shouldn't eat all this is between meals. That means that, for example, you eat lunch at 12, then maybe at 1 o'clock you eat a biscuit, 2 o'clock you eat another biscuit, 3 o'clock you eat another biscuit. You will get decay more easily that way. Even things like freeze-dried strawberries or freeze-dried fruits in general, if you've had them yourself, you realize they stick on the teeth a lot too. So these are also, again, better taken during mealtime. Same for juices, same for multivite gummies as well. They're very sticky. So not say no, but but you need to time it appropriately so that they're not taking it between meals and they're not taking it very frequently throughout the day. So even like formula milk, like I mentioned just now, again, very sugar added inside and quite sticky. So not a no, but just be mindful of when you're giving as well as how frequent as well. Okay, I wanted to touch a little bit on thumb sucking and pacifier. So a lot of children do thumb suck, they do use pacifiers, and that's fine as long as they are not yet 3. So a lot of infants who are on pacifiers, thumb suck, that's okay, and that's not something that you need to change because they use it as a way to self-soothe, they use it as a way to fall asleep. There's no issue with it. But you will find that beyond 2 years old, you may start to see a little bit of changes to the alignment of their teeth. So this is actually a patient of mine. You can see that this is with him biting down all the way. There's this huge gap between the top and bottom teeth, and this is where his thumb is at. So what the thumb sucking or the pacifier does is that it pushes the upper teeth upwards and forward, such that when he bites together, he cannot bite together. And the problem with having this is that not only does it cause the teeth to be crooked, the front teeth are protruded, it also causes this open bite. Cannot eat things like noodles. You try to bite together, cannot bite. Cannot touch, the teeth cannot touch. Then you will find that you have to cut everything smaller, and they generally use their back teeth to eat because the front teeth cannot touch, not functional. But over time, you'll find that with this gap, they cannot pronounce things properly. So they learn how to adapt to this gap by putting their tongue there. So to create the sounds that we normally make, or the kind of words that we want to produce in a proper way, they want to pronounce properly, they will have to put their tongue to block that gap. And that's an improper tongue position, which has a lot of downstream effects. Like it doesn't allow the tongue to grow properly. It doesn't allow the jaw to grow properly. So generally, we try to stop any thumb sucking or pacifier habits by the time they are 3. And you'll find that if that's the case, usually any changes to the alignment that you may see due to the thumb sucking or pacifier, it will actually close up quite nicely. But beyond 3, the chances of it spontaneously closing up is a problem. And it can even carry on to the permanent teeth, even though the habit has stopped. So generally stop by 3 years old. And these are the little things that you can do in order to encourage them. Sometimes it's just reminding them again and again. I find that a good age to embark on this is also important. So you need to start at about 2 years, 9 months. If you start too early, you will find that you will be met with a lot of resistance and a lot of failure because your child doesn't understand. So timing it appropriately is very important. So right time and then commit to it. So you cannot like, oh, so difficult, and then you give up. So it does take time to break a habit. Sometimes it takes 1.5 weeks, sometimes it takes 2 weeks. So you just have to bite the bullet and do it. There are little things like rewards, praise and encouragement, reminders. You can even cut your pacifier very gradually so that it becomes harder to hold in the mouth. You can also try to limit and reduce usage. You can say, okay, one day can use, one day cannot use, and then gradually drag it out. Thumb sucking is a little bit harder to stop because you cannot alter the thumb. But there are also things that you can wear on the thumb in order to make it less, not as appealing to sound their thumb. They have guards that you can wear on your thumb, gloves, they have bitter nail polish. But I always say you have to couple in this together with a reward system. Otherwise, they will think that like, my mommy says no and I cannot do it, which a lot of children find that is like going head to head. Whereas what you should do is you should say like, okay, you bring them to see a dentist, and then the dentist says cannot, must stop pacifier. So you see the dentist auntie say you must stop pacifier already, or you must stop your tongue sucking. So mommy will help you. I will put this on your hand. I will put this so that you don't suck your thumb anymore. And if I see that in the morning you haven't sucked your thumb yet, you get 1 sticker, then 2 stickers. So this is like coupling a reminder in together with a reward system. Okay, so I wanted to talk about what prolonged thumb sucking and pacifier usage can do. So this is a much older kid already who has stopped his habit a long time ago, but you can see that his upper arc is very, very narrow, and because of that, he now has problems breathing from his nose. So he breathes a lot through his mouth. So because he breathes a lot through his mouth, you'll find that his lower jaw is very backward, it's very small. So we need to do intervention at this stage because it's not as easy as, oh, you stop your habit, because his habit was stopped too late. So what happens is that the jaw and even the adult set of teeth are all affected. So then he has to wear all these appliances, which is why it's also very important to bring your child who is around 7 or 8, even though they are past the preschool age, for a dental visit. Because if let's say there are any of these jaw or arc developmental problems, we can intervene so that we can change it and make it better. And it's a lot easier to intervene when a child is growing rather than to do something once you're an adult. Usually as an adult, you have to do surgeries already because you're no longer growing. But as a growing child, you still have this opportunity to encourage the growth or stop the growth of certain things so that we can make everything more, your jaw growth more optimal. Okay, so almost done. So I was mentioning about how when your child is around 5+ to about 8 years old, that's when the upper and lower front teeth change. But the back teeth only change from 10 to 12 years old, which is why it's so important that we make sure that oral hygiene is kept oral hygiene is good so that we don't get decay, particularly at the back teeth. So this picture over here, I included it because it's one of the other more common cases that I see. People coming in telling me that the adult tooth is growing out, but the baby tooth still hasn't dropped yet. So really case by case scenario, it's very normal for the adult tooth, especially for the lower front teeth, it's very normal for the adult tooth to grow out behind the baby tooth and the baby tooth still be present. But if the baby tooth has still been there for 3 months, not wobbly at all, and the adult tooth is almost the same height as the baby tooth, then you need to get it taken out. But if you see that the adult tooth has just grown out a little bit, the baby tooth is actually quite shaky already, you can afford to wait a little more so that you can let the baby tooth fall out by itself. I just put this slide in because it is very common. I would say that I see cases like this, at least 2 or 3 every day coming in for this exact same thing, and they come in telling me that it's like shark teeth or double teeth. So I just want to reassure you that for the lower front teeth, it is okay and it is normal to have double row of teeth for a short while. Okay, so first dental visit we recommend by 1 year old, which sounds, I know, very young, but why do we want a first dental visit by 1 year old? It's because we want to check early on to make sure that your child's teeth are developing correctly, not only in terms of order, but also the quality of the teeth they have. We want to check things like lip tie, tongue tie as well. So all this will be done during a dental check. We also will educate parents on what to do, how to brush, what do you use. And this is very important because if you know it from the get-go, it's a lot easier to establish when your child has got very few teeth. As your child gets more and more teeth, the brushing gets harder because there's just more teeth. So we try to do brushing when the child is very young, when they only got 1 or 2 teeth, and you'll find that takes like 5 seconds, and then as they get used to it and they need maybe longer, 1 minute plus to brush teeth, at that point of time they'll be comfortable already. A lot of people don't brush teeth and then suddenly the child has got 20 teeth and then they were like, now I need to brush teeth, but it's very hard to brush teeth now because your child is stronger, more teeth, not used to brushing. Teeth are also dirtier, so early visit helps a lot. Okay, and when your child comes early, they may cry the first time, but you'll find that the second time when they come, they are a lot more cooperative. So most children are uncooperative at their first visit, or they are scared because they don't know what is going to happen. But the younger you bring your child, the earlier they get used to a dental clinic, and you'll find that they'll be able to do things like maybe cleaning and all at a much earlier age compared to a child that has just come for their first dental visit at 5 years old. Okay, so this quote that I have is that children who did not visit a dentist before 2 years old are 3 times more likely to get tooth decay as compared to those who have visited the dentist regularly since 0 to 18 months old. So starting dental visits early can help to prevent a lot of further future treatment that your child may need by preventing decay in the first place. Okay, so these are just a little bit of things that you can do in order to prepare your child for a dental visit. So you can no fear mongering. So I don't like people saying that like if you don't brush your teeth, the dentist will pluck out all your teeth. So I have a lot of children who have seen me for first time, never had a dental experience before, but they come and say, I don't want you to pluck out my teeth. Then I almost immediately know that someone in their family has been telling them that if you don't brush teeth or you eat too much sweet, the dentist will pluck out your teeth. So I mean, generally when the child comes, they see me and then they start crying. I'm like, oh, okay, like I didn't really do anything, but they're very scared of me already. So we try not to not to threaten them with like the dentist plucking out their teeth, or like dentist auntie will scold you. Okay, I'm not so mean. Okay, so I also would like to, you can prepare your child reading them books, letting them watch some show, preparing some reward, like after auntie counts your teeth, you can get this present. It helps. You want to avoid nap time, make sure that they're well rested, they're not cranky during the dental visit. Come prepared with questions. So any questions that you have them at, know them already, so you can ask the dentist and can maximize your visit. And lastly, also manage your own expectations, knowing that your child is still a child, and if they come for the first time and they are young, they may be a little upset during the check, but that's normal because a lot of children will come for the first time, naturally assume that the dentist or the doctor will give them a vaccination, which I'm not going to give a vaccination. So Okay, so that's all for my talk, and I'll just leave you with this small little reminder that it's better now than later, and that prevention is key. So I much rather see children and do easy things like cleaning, rather than to see and tell you that your child needs to do extraction, need to do filling, need to do crowns. I would like to avoid that. Of course, I do see my share of that, but really, prevention is better for everyone, for myself, for your child, and for you as a parent as well. So yeah, don't underestimate dental care. Yeah. Okay, thank you.
So I have a question.
Yeah.
A question to my wife first.
Oh.
Is your son using fluoride toothpaste?
Wait, we have some questions here online. Okay, later, but first of all, is there any way to help my child have straight and nice teeth?
Okay, I mean, it really depends on how old your child is. If you're saying that your child is like very young, like maybe 3 or 4 year old, and you see your child has a bit of crooked teeth, then I would say it's too young for us to do anything, mainly because anything that we do for your child, it will be very hard for your child to comply with because they're very young. Once your child is about 7, 8, 9 years old, and you start to see the upper and lower adult teeth coming in, we can actually do something. So depending on why there is crowding, like why there are crooked teeth, is it because the jaw is too small, like abnormally small, or is it because of genes? Sometimes mother, father both have very crooked teeth. You cannot expect your child to have straight teeth, right? So sometimes it's just genes. Sometimes your genes is just that you are going to have crooked teeth, and there's nothing that we can do in order to make it better. But there are situations where the jaw is not growing optimally, then we can help. We can also help to straighten teeth, even though not all adult teeth yet. Yeah, so with the upper and lower front adult teeth out, we can already tell whether or not you can do anything. So it's very hard for me to comment without seeing the child first. But yes, it's possible, but need to bring for dental consultation. Yeah.
Thanks, Jessica. There are 3 more. Though I brush my child's teeth, he has smelly breath sometimes. What can I do?
Okay, so smelly breath can have many reasons. If you're talking about teeth, then it could be things that are stuck between the teeth. Maybe you don't floss. Maybe the brushing not being done so well. So need to check, see if there's anything, because a lot of us think that we're doing a very good job with brushing. But the truth is that even as a dentist myself, I cannot safely say that I brush 100% of the dirt off my children's teeth every single day. I would say maybe I get 80%, 90%. So over time, there's always a little bit of build-up, and it's always at areas where you cannot see and you cannot brush. So it could be those areas that are causing the bad breath. But there are also other reasons. Mouth could be very dry. Sometimes a lot of mouth breathing can also cause bad breath. So first, again, I am encouraging you to come for a dental visit, but I think to answer this, a dental visit is also very important.
Thank you. Okay, another question from one of the audience. My child chipped her front teeth due to her biting during the early years. Will it resolve itself when it eventually drops?
If you're saying that her baby tooth has got a fracture, will it resolve itself? It will lah, because the adult tooth will grow out, and the adult tooth is independent of the baby tooth. So the baby tooth chip will not cause the adult tooth to get chipped also. So will it resolve? Or sometimes the chip can get a little less chipped looking because with time the tooth wears down. So if the chip is at the edge, it may look very bad at the start, but as the years go by and she uses it to bite, it actually gets a little shorter, and you may find that the chip is not so obvious. Yeah, I hope that answers your question. But if you're asking whether the adult tooth will get affected, it's unlikely unless the baby tooth was infected in the first place. Yeah.
2 more questions. This one is a combined question about toothpaste. When is it time for my child to swap to adult toothpaste, and what happens if the child actually swallows quite a bit of the toothpaste?
Your child can transit over to adult toothpaste whenever they are okay with the minty taste. Because adult toothpaste, most of them, sold locally, they do have enough fluoride. That means more than 1,000. But I think the thing that prevents us from using it in children is the taste of it. It's too minty, so they will not like it. So you don't want them to use a toothpaste where they don't like. Then it makes your brushing more challenging. So if your child is comfortable with like mint sweets, okay with like minty taste, then you can transit over already. But the amount that you use is, like I mentioned just now, only a pea size, never more than that. If your child swallows too much toothpaste, so too much toothpaste, if like they eat one whole tube, like maybe you say at the corner, love the taste of the grape flavor toothpaste, eat one whole tube, then can get some systemic toxicity lah, but nobody really does that. So main thing is really to keep toothpaste out of reach, and toothpaste should only really be dispensed under supervision from an adult. If you're dispensing a lot of toothpaste on your toothbrush, like one whole length of it, and your child swallows it every time you brush teeth and it's a high fluoride toothpaste, you may find that it can affect the adult teeth. So when adult teeth grow up, you may see, when the adult teeth come out, you may see that there are these like white patches on it, sometimes even brown patches, and this is what we call fluorosis. That sometimes happens when children who are young, like, you know, the 2, 3, 4 year olds swallow a lot of the high fluoride toothpaste, like on a regular basis, quite a bit of it. So controlling who brushes, controlling how much is dispensed is both very important. Yeah.
Thanks so much, Jessica. This is the last question from our audience. My 15-month-old rolls around and uses her lips to hide her front teeth whenever we brush her teeth. Any way we can make the exercise more enjoyable for her?
Okay, it's quite normal for a child to actually tighten their lip. I get what you mean. So sometimes when they tighten their front lip, it's about how we lift up the lip for them. So what you want to do is you want to not pinch the lip and push up, but what you want to do is you want to slide your finger at the part where the lips, the deepest part of the lip, and then you do a push up. So even if she tightens her lip, she's actually tightening around your finger, and that will actually hike her lip up and still expose the gums for you. So you can of course tell her relax, but the irony is that sometimes you tell them relax more, they tighten their lip even harder. So instead of doing that, you just like, okay, brush teeth, and then how you position your finger such that you're actually hiking up the lip so that even she tightens on your finger and you can still see along the gum line. Again, the positioning that you put her in is also very important. Lying her down will allow her to not roll around as much as well, especially when she's in that valley that's between your legs. You'll find that, okay, maybe she moves left and right a bit, but she can't really roll. Yeah, so positioning as well as technique matters a lot. Yeah.
Any more questions from the people here?
I was asking about fluoride. So I think my child always swallow his toothpaste, but if it's a minimum, every time it's okay, right?
Is this the child that you're carrying?
No. 3 years old, he's 3 years old.
Oh, okay, yeah, that's fine. But we still really try to encourage them to spit. And other ways that you can help to prevent like how much toothpaste he's swallowing is while you are brushing, let him spit midway multiple times. So sometimes we have this habit of like waiting till we finish brushing, then let them spit. But what you can do is you brush, maybe one corner, then okay, spit, then spit, then okay, continue, then spit, continue, then spit. So most of the time, children tend to take a gulp of the toothpaste when they feel that there's a lot of the bubbles in the mouth and a lot of the saliva. Then they don't know what to do with it, then they swallow. So you can midway let them spit multiple times. This further reduces it, and of course control the amount of toothpaste you're dispensing. Yeah.
This is 1 year old. Do we need to use fluoride?
No need. So just no toothpaste for now.
Okay, actually, because my wife also, because we are concerned, because we always brush his teeth, very difficult, you always chew, don't cooperate. So we were thinking of bringing him to the dentist, but the dentist was saying that, wait until he's more cooperative.
That's why I say pediatric dentist is different from dental GP.
Oh, okay.
A lot of dental GPs will not be comfortable seeing very young children because they will think like, okay, there's not much to say, not much to do, not much to check. But that's what our additional training helps us with. Yeah, it equips us with these skills to see the kids better and to better educate. Yeah, so not too young.
3 years we can bring him.
Definitely one should bring already.
Okay.
Yeah.
Any other questions? If not, thank you so much, Jessica, for making the time for giving us this talk. And we have our preacher, Brother Ben, who will present the token of appreciation.
Thank you. Thank you. No, thank you for having me. Thank you so much. Thank you for.
Okay, thanks everyone. We'll have a short, 5-minute break, then we'll come back. Thank you. Fellowship of the Royal College of Pediatrics and Masters of Medicine in Pediatrics in 2018. She is also a clinical lead in the Anchor Start program in KKH, which aims to optimize the health and overall well-being of children from vulnerable families who are exposed to challenging circumstances or traumatic events. Dr. Grace Le is also a busy mother of two and is married to Joelle Lee, another member of the Eastside Church of Christ and also who was one of our speakers from last year's health seminar. So thank you, Grace.
Okay, hi everyone. Thanks for the kind introduction. So I'm honored to be able to give this talk today to share more about managing fever and also common pediatric conditions. Hope this information will be useful for you all and help you all to be more confident in managing your little ones when they are sick. So today I'll be covering these few topics: fever in children, the causes and how to manage, febrile fits, upper respiratory tract infections, gastroenteritis, as these are very common infections in the young population, as well as preventive strategies and vaccinations. So what is fever? So fever is a normal response of the body to a variety of conditions. It results from the body's thermostat being reset to a temperature that is higher than normal. And in children, the definition is actually a little bit different from adults. So in adults, we usually take 37.5 degrees Celsius as fever, but actually in children, we allow a higher threshold of 38 degrees. So how should we measure our child's temperature? For less than 6 months old, actually using axillary temperature, which is measuring through the armpit, is more accurate. And then for children who are more than 6 months old, we can actually measure using the tympanic thermometer, which is through the ear. So commonly, parents also use the infrared thermometer by just shining it on the child's forehead. It may be convenient, but sometimes we find that it's not as accurate. So these are the more accurate methods of measuring the temperature. So there are many causes of fever in young children. The most common cause is actually infections, which can be viruses, bacterial, and some of the viral infections are actually still the most common cause of infection. Some viruses can actually cause quite prolonged fever and very high temperatures. Bacterial infections will then, on the other hand, will actually need antibiotics to help with the infections. Post-vaccination is also a common cause of fever in the young children, as they do go through many vaccinations, and this fever usually lasts for 1 to 2 days. In terms of inflammatory causes, Kawasaki disease is one of the more common cause of inflammatory cause of fever in children. So some of you may have already heard about this condition, as there's more awareness of this. It causes red eyes, red lips, puffy hands and feet, swollen lymph nodes in the neck region, and also a rash. Immune disorders like autoimmune conditions, cancers like blood disorders, and other rarer causes like medications and hormone disorders like thyroid problems can also be causes of fever in young children. So a very common question that I get is, does fever cause brain damage? So actually, fever in itself does not cause brain damage unless it is caused by infections or inflammation of the brain. Then that can result in more long-lasting effects. So what should I do when my child is having a fever? So that's also a very common question that parents ask. For example, should I sponge or bathe my child in cold water? Should I switch on the aircon to bring down the temperature? Should I wake my child up for fever medications? And when should I bring my child to see a doctor? So the next few slides will address these questions. So in terms of managing fever in a young child, firstly, to keep them hydrated. A lot of times when they are having fever, they don't tend to drink or eat so well, so they tend to get dehydrated more easily. So encouraging them with small frequent feeds will help to keep them hydrated. Actually, sponging with room temperature or lukewarm water, in contrast to cold water, is more beneficial, because actually when we sponge them with cold water, it generates a lot more shivering in the children, and that can cause them to feel more uncomfortable as well. So we also discourage using aircon when they are having fever also. Dress them in light clothing, keep the room cool and well ventilated, and you can also use fever medications to make them feel more comfortable. So I'll be going through some common fever medications that parents can easily obtain over the counter to help with the child's fever. So it mainly just helps to reduce the discomfort that is caused by the fever. So you can use it, for example, when they are very irritable, when they're feeling unwell and they don't want to eat, then sometimes when you bring down the fever, they do feel better and more active and they're more willing to eat as well. But if let's say they're actually very active, they're not disturbed by the fever and they're sleeping well, there's no need to wake them up just to give them the fever medications. So I think parents would be quite familiar with these two types of medications. So the first one is paracetamol, and the other one is ibuprofen or diclofenac. So paracetamol can be used for babies who are more than 3 months old. We would recommend any baby who is less than 3 months old with fever to seek medical attention first instead of parents just giving paracetamol. Paracetamol can be given orally or via suppository through the backside, and it can be given every 4 to 6 hours. For ibuprofen, it can be given for children more than 6 months old, and it can be used when fever is persistently more than 38.5 degrees, about 1 to 2 hours after paracetamol. Ibuprofen can be given every 6 to 8 hourly, and diclofenac every 12 hourly. So a lot of parents also ask me, oh, should I give paracetamol and ibuprofen at the same time or should I stagger them? So what we usually advise is you can give paracetamol first and then measure the child's temperature again about 1 to 2 hours after that, and if the child is still having fever, then you can give the ibuprofen. So this will actually allow us to have more medications to give round the clock if they are quite disturbed by the fever. Otherwise, if you give both at the same time, then in a few hours time, if your child is still having fever, then you have no other medications to give already. Also, do note that for ibuprofen and diclofenac, they are in the same class of the same family of medications, so we should not give them together. And we should administer the medications with food or milk, and to be used in caution when the child is not feeding or drinking well, as this class of medication can cause a bit of gastric pain, gastric symptoms as well. And if your child has severe vomiting or bleeding disorder, then we would recommend not to give this medication as well. So when should I consult a doctor? So sometimes the fever can be very high, like in some children it can reach up to 41 degrees. So some parents will be very worried and they bring the child in. So unless it reaches 41 degrees, we will say actually if the child is very active at home, you can still monitor. But fevers that reach 41 degrees are have a stronger association with bacterial infections. So if it does reach to that degree, we would say you should bring your child in for a check. Sometimes, most likely we'll do some blood tests to just rule out bacterial infections. But if let's say it's less than 41 degrees and they are very active, then there's no need to bring the child in. If let's say your child is less than 3 months old, they are feeling poorly, vomiting or lethargic, then they should seek medical attention as well. If there's also decreased urine output, as these are signs of dehydration. If they have difficulty breathing, appears sick or is drowsy, has other symptoms like abdominal pain or rash, then we should also bring the child in to see a doctor. Most of the time, viral fevers tend to downtrend between day 3 to day 5 of the illness. So if let's say they are well, you can still watch at home, but more than 5 days, you should also see a doctor just to make sure it's not due to other reasons. So the next topic that I will cover is febrile fits. So what is febrile fit? So febrile fit is actually the most common type of seizure in young children. 2 to 5% of children between 6 months to 6 years of age actually experience a febrile fit. And it's usually triggered by rapid rise in temperature. So it's not just the fever itself, but it's more of the rapid increase in the temperature of the child that triggers off the febrile fit. And 1/3 of the population may have repeated episodes until 6 years of age. So most of the time, most of the febrile fits do stop spontaneously on its own within 5 minutes, and the child regains consciousness shortly after that. And those lasting less than 15 minutes usually have no long-term health issues. But for seizures that are more prolonged, lasting more than 30 minutes, can lead to more serious complications. And studies have also shown that use of fever medications do not reduce the likelihood of a febrile seizure. So although seizures can be very alarming for caregivers, I think it's still important to always remain calm when the child is having febrile fit as well. So signs and symptoms of a febrile fit. So you may notice that the child is having uprolling of eyes, there's frothing at the mouth, stiffening or jerking of limbs, and the child is not conscious. So what should you do if your child is having a seizure? So it can be very alarming, but it's important to stay calm, especially if you're the only adult there. Ensure that the environment is safe. So if there's any dangerous objects around, if your child is near the swimming pool or near somewhere that's not so safe, you should move the child. Clear the area of any sharp objects to prevent any injury. Loosen your child's clothing, and it's important to position your child on the side. So this will actually help, for example, if your child vomits or there are a lot of saliva, then it will help it to flow out and prevent the child from choking on the secretions. Don't put any finger or object in the mouth. So I think in the past, a lot of parents will also be very concerned that, oh, what if my child bites the tongue during the fit? Will my child die? But actually, it will not happen. So I mean, if the child bites the tongue, there may be some bleeding, but it's not life-threatening. But what's more worrying is if you put, for example, an object, or you can cause injuries in the mouth, or sometimes you can knock off a tooth and they can actually choke on the tooth, and that can be more dangerous. So avoid restraining or holding down your child. So by holding down, it doesn't help to stop the seizure at all. It may actually cause the child to get more injuries or bruises after that as well. And it will be important to observe the type and the duration of the seizure. So for example, is it the whole body is shaking, or do you find that only one side of the body is shaking? So that will actually make us think of different types of causes of the seizure as well. And then we will also ask parents to also note down the duration of the seizure, how long it is, and if let's say it's more than 5 minutes, to either, if you have a nearby doctor, you can quickly go to the nearby doctor or call the ambulance so that they can give medications to stop the seizure. So you can stay with your child until normal breathing resumes and they regain consciousness. Okay, so this is actually a video on what you can do when the child is having seizure. I'll do the audio then. Okay, sorry, there's some technical errors, but it's okay. We will just go through the. How to restart the thing? Okay, so this video is actually talking about seizure first aid. Actually shows you what you should do. Or how you can help if you see someone having a seizure. So this applies even to adults as well, not just young children. So it just talks about 1 in 10 people with a seizure. So you can see in this video that they are actually turning the patient to the side. So instead of letting them lie on the back, it's important to turn the patient to the side, remove any dangerous objects. So this would help, for example, if they vomit or there's a lot of saliva, it will help it to flow out more easily. Then it's also important to see the timing of the seizure so that you know how long this seizure is happening.
Most seizures last 2 to 3 minutes and stop on their own. If a seizure is prolonged and goes on longer than 5 minutes, someone should call 911 so that medical assistance can be provided. You might want to look and see if the patient is wearing a medical bracelet so that we can determine if they have a history of seizures. It's important to remember these 3 steps. Stay safe side. Stay with the person until the seizure is over. Make sure they are safe. Turn the person on their side and make sure they are comfortable. So it's important to understand that when a person's having a seizure, they probably won't remember what it's like to have a seizure, especially for the convulsive seizures. They may remember something before the seizure, a funny feeling or that something doesn't feel right, but usually the seizure itself is not something that a patient remembers. When the seizure stops, they're often confused and they may not know what's happened. So it's important to comfort them and tell them that they're safe and make sure that they know that everything's okay. I would say if you find someone who you don't know and you don't know their history, that you should call 911 anytime you come upon someone having a seizure, but still follow the stay safe side recommendations. If it's a family member or someone you know with a history of seizures and you're comfortable and the seizure ends in less than 5 minutes, it's okay to not call 911. If they recover from their seizure and they're back to baseline, you can just monitor them at home. You should never put anything in a person's mouth when they're having a seizure. It is not necessary and it can be harmful to both you and the person. All we need to do is the steps we've already discussed, put them on their side, keep them safe, and stay with them. 1 in 26 Americans has epilepsy. At some point, you or someone you know will have a seizure, but now you know what to do. Make sure to seek out communities like the Epilepsy Foundation.
Okay, so this video just mainly shows what are the steps you can do to, if we do see somebody having a seizure.
Actually, I have a friend last time, every time he seizure, they will put a metal spoon in his mouth. So no more already, is it?
Yes, so we shouldn't do that because you can actually cause more injuries to the person as well.
Alright.
Yeah. Okay, and when should we bring the child to the children's emergency? So if it's the first episode of febrile fit, we would recommend to bring the child to the emergency so that they can have the doctors can have a check. If the child shows any signs of a stiff neck, becomes confused, the interaction with the parents is not the same as usual, he's maybe speaking sentences that you don't understand, persistent drowsiness or behavioral changes more than 30 minutes after the febrile fit, appears unwell, or there's more than one seizure in a day or lasting over 5 minutes, then we would recommend to seek medical attention and call the ambulance, mainly because sometimes it's not just the usual febrile fit, but more of other kinds of causes of seizures in children. So there are many causes such as infections, inflammation of the brain, salt imbalances. So these are some of the other reasons that we want to exclude if your child has all these symptoms as well. Okay. So the next topic that I will go through will be the upper respiratory tract infection. So these are very, very common infections that we see among children, especially children who go to school. A lot of parents will tell me that they come back with like flu symptoms every 2-3 weeks. They get better, then they go to school, and then they come back with similar symptoms again. So it's actually a broad group category, and they can be categorized into, for example, the common cold or flu, sore throat, tonsils infection, or this condition called croup, where the upper airway is affected. So symptoms usually peak in the first few days of illness, and they gradually get better over the next 10 to 14 days. And most commonly caused by viral infections, which usually resolves within 5 to 7 days. Although nowadays we do see with certain viral infections such as influenza or adenovirus infections, we have seen up to 10 to 14 days of fever as well. Some of the upper respiratory tract infections are caused by bacterial infections and would then benefit from antibiotics. For viral infections, we don't recommend giving antibiotics because it's not effective, and then they may actually get side effects from the antibiotics, for example, diarrhea or even allergic reactions. So management-wise, is actually mainly just to make sure they are comfortable, make sure that they are hydrated as well. So to rest as much as possible, drink lots of fluids and medications if needed to help to alleviate their symptoms. So these are some common medications that parents can also buy from over the counter. So if let's say the child is having blocked nose, you can get Sterimar. So it's a nasal spray where you can just spray into the nostrils to help decongest the nose. So especially it will be very useful if you find that they are having sometimes they look like they're having difficulty breathing because the nose is so blocked, so you can use that. Or sometimes when the babies, they're having difficulty feeding because the nose is blocked and they can't suck on the milk water very well, then giving the Sterimar to decongest the nose will also help the symptoms. And because it's mainly just saline inside, not like medication, so it can be given as often as needed. for Iliadin, which is the one on the right, top right corner, so this is used for blocked nose, but there are age, like different concentration for different age groups, so you will need to check the box to make sure that the correct concentration is given, and it can be given up to 3 times a day, up to a maximum of 5 days, because after 5 days they tend to get rebound congestion, so then the symptoms get worse instead. So we will say give for 5 days maximum and then you can stop. Cetirizine, or also known as Zyrtec, can be given for more than 6 months old and is used for runny nose, and it's given once daily. So this is a non-sedating antihistamine, so it doesn't make the child feel sleepy. And if your child is also having fever, then you can also give some fever medications as well. So when should I consult a doctor? So you can consult a doctor if your child is also similarly less than 3 months old, has any signs of dehydration. If your child has difficulty breathing or noisy breathing, then we are worried that it could be, if let's say there's noisy breathing, we are worried that it could be croup, where the upper airway is affected. Or if there's difficulty breathing, then we are worried is whether it has progressed to a lung infection. If your child is drowsy or lethargic and appears more unwell, then it will be important to see a doctor as well. So actually, you can also go to GPs and polyclinic doctors. They are actually well equipped to manage children with upper respiratory tract infections. But unless your child is having difficulty breathing, looks quite unwell, very lethargic, not the usual self, then you can bring to the children's emergency earlier. So next would be gastroenteritis. So gastroenteritis is also a very common infection among young children as well. A lot of the patients I see in the hospital are admitted mainly because they need hydration. So what exactly is gastroenteritis? It's also known as stomach flu or food poisoning. It's an intestinal infection that's usually caused by viruses or can also be sometimes caused by bacteria. Similarly to adults, it's commonly transmitted through contact with an infected person's fluids or by consuming contaminated food or water. So especially if, let's say, you find that there's one person in the household who is down with stomach flu symptoms, the whole household tends to also have similar symptoms because it does spread quite easily. Mainly it's through, for example, not washing your hands thoroughly after going to the toilet, then that can cause the spread of the germs more easily. So symptoms would then include diarrhea, vomiting, tummy pain, fever, and loss of appetite as well. So what can we do if your child is having gastroenteritis? So it's very important to make sure they are hydrated. So you rehydrate. There's also this oral rehydration salts that are available in the pharmacies as well. That actually contains sugar and salt, so it's not just plain water. So that would also help if, let's say, your child is not drinking well. There's also risk of salt imbalances or low sugar also. If you find that your child is vomiting, then it will be important to give small frequent feeds, mainly because when they are having gastroenteritis, their tummy is very bloated. If you give large amounts of fluids at one go, they can actually tend to vomit. So by giving small frequent feeds, it will help them to tolerate the feeds more easily. Sometimes parents will tell me, oh, but they're not eating now, they're not eating solids for a few days, is it okay? Actually, it's okay if it's just a short period of time, because sometimes when their stomach is feeling unwell, having to tolerate the solids, it will make it more difficult for them. So as long as they are able to drink fluids and they are not dehydrated, then that is the more important thing to note for that period of time. But after the symptoms get better, then actually their appetite will also slowly come back as well. We also give probiotics if they are having diarrhea to replace the good bacteria in the gut. And only if really necessary, then we will start them on anti-diarrheal medications, and there's also age limit for certain medications as well. Most of the time it is self-limiting, means that after a few days the symptoms get better on their own and they don't require any anti-diarrheal medications. Also because certain anti-diarrheal medications can affect the intestinal movements and cause quite severe side effects as well. So we don't recommend it unless it's really necessary. So when to consult a doctor if your child is having gastroenteritis, if let's say your child is less than 3 months old, having signs of dehydration again, if there's severe or persistent bouts of vomiting or diarrhea, mainly because then they may require intravenous hydration, like a drip, to help with their hydration. If let's say there's blood and vomit or stools, the vomit is green, or there's very bad tummy pain, the tummy is very distended, then we are worried about other causes that is in the tummy that could be causing all these symptoms and not just a normal simple gastroenteritis. Or if the child is very lethargic or drowsy, then you should also bring your child to see a doctor as well. So what are the preventive strategies that we can do to help our child. So I'll be covering that as well as a little bit about vaccinations. So in general, having a healthy, balanced diet would help, because then they can get the different types of vitamins and nutrients from the diet. Actually, it's not necessary to give vitamins to the child. If your child is having a balanced diet, they would be able to get all the different types of vitamins they require through the food that they take. Maintaining good hydration as well as good quality sleep to help ensure your immune system is on track as well. Infection control, so hand hygiene, making sure you wash your hands, avoiding people who are sick or wearing masks would also help. And routine vaccinations based on the National Childhood Immunization Schedule. So vaccinations for certain viruses and bacteria such as like influenza, COVID, rotavirus are actually available. So this is the National Childhood Immunization Schedule. That is the recommended schedule of the vaccinations from birth all the way to when they are in the teenage years. And this can actually be found in the health booklet as well. So I think a lot of parents will be quite familiar with this, because you would see the health booklet, and then this would be the schedule that you will actually follow and make appointments for your child to do the vaccinations. So how do vaccinations work? When vaccines are given, then our immune system reacts by making the antibodies, which give us immunity. It helps to protect our child from contracting the disease when exposed later on. So it reduces the chance of them having the condition. But if they do get the condition, it actually helps to reduce the risk of severe complications. Most babies and children are fit for vaccinations, but if let's say your child is having a high fever at the point of time when they are due for vaccinations, or they had a previous serious reaction to certain vaccines, or they have an underlying medical condition, then it would be good to consult the doctor before you get the vaccinations. So what are common side effects of vaccination? So commonly they do get fever that lasts for about 1 to 2 days after the vaccine. They can have some soreness, redness or swelling at the injection site. So you can do some cold compress, or you can give some painkillers for them. For BCG vaccination, which is usually given at birth, it can cause a small boil to develop about 2 to 3 weeks later at the site of injection. And most of the time, after 6 to 8 weeks, it will resolve on its own. For MMR vaccination, which is the measles, mumps, rubella vaccination, that's usually at 12 and 15 months, is 2 doses. It can cause a reaction that starts from a few days all the way to 3 weeks after the vaccination. And it includes mild cough, runny nose, rash, fever that's usually on the 5th to 10th day, which is a little bit different from the other types of vaccines, or swollen salivary glands. So now I'll be just going through some of the vaccination myths. So to just try to debunk these myths and reassure parents. So the first myth is it's not safe for my child to take multiple vaccinations at the same time. So actually studies have shown that giving more than one vaccine at a time is just as effective and does not increase the risk of harmful side effects. And when you give multiple vaccinations at the same time, it can provide early protection to multiple diseases instead of having to wait so long, and also reduces the number of painful injections and the number of times of visits to the doctor for vaccinations alone. The second myth is that majority of people are vaccinated, which is what we call herd immunity, and so my child doesn't need to get vaccinated. So vaccines are not 100% as well. A small number, about 5 to 15% of people who are vaccinated do not develop immunity, and they can still catch the disease and pass on to your child if they are unvaccinated. So herd immunity does not protect your child at the same level as vaccinations do, and it's not a substitute to getting vaccinated. The third myth is it is better for my child to get natural immunity by getting the infection itself rather than rather than vaccine-induced immunity. So acquiring natural immunity through certain infections, although can be effective, but at the same time can be dangerous because certain infections can lead to severe and life-threatening complications. So for example, if you have heard of measles infection, it can actually cause lung infection, inflammation of the brain. Chickenpox can also lead to severe skin infection as well. So vaccines actually can induce an immune response that is similar to natural infection, but without causing the disease itself, and hence minimize the potential for any serious health consequences. So this is also a very common myth that the MMR vaccine can cause autism. So this fear of the MMR vaccine actually causing autism actually originated from a paper that was published in 1997 that suggested a link between getting the vaccine as well as autism. However, it was found that this paper was actually the results were actually falsified, and this paper was then subsequently retracted. All the other large-scale studies that have been performed after that have found no link between the MMR vaccine and autism. So actually what is more plausible is that because the MMR vaccine is given at about the 12 to 15 months, previously it was given at about the 18 months, the second dose was given at 18 months old previously, and that's also the time where some developmental concerns may be more obvious in children as well. So some parents may falsely think that, oh, when they get the vaccine then they get this developmental delay or autism, but actually there's no link that's found. Okay, and the last myth that I will go through is MMR and influenza vaccines cannot be given to children who are allergic to egg. So MMR vaccine is actually grown in the fibroblast cells of chick embryos and does not contain any egg element. So it's actually safe to get MMR vaccine. It's safe to give MMR vaccines to children who are allergic to egg. For influenza vaccines, they are derived from the viruses grown in chicken eggs, and so they may contain very small amounts of egg protein. But most children with egg allergy are able to receive the vaccine safely with no or mild side effects. However, children with history of life-threatening allergic reactions to egg would then be advised to take the flu vaccine in a medical facility so that it will be safe, and if they do develop a serious allergic reaction, then the treatment can be given. Okay, so I've come to the end of my talk. Yeah. Thank you, everyone. Yeah. Are there any questions?
Yes, quite a few. Okay. Thanks so much, Grace. Okay, so this question is asking, is chickenpox vaccination recommended and necessary?
Yes, so chickenpox vaccination is recommended. It's also given around the same time as the MMR, which is the 12 and 15 months. And for the second dose, actually, they can give together, so it's a single injection. So we do recommend because it can reduce the chance of getting chickenpox, and if they do get chickenpox, the effects may not be so severe.
Another question about vaccinations. Are there other vaccinations that are not part of the mandatory national schedule that would be useful to get?
Okay, so one would be COVID vaccination, because now we do know that there's like an increase in COVID vaccination rates again. So COVID vaccination is, although it's not mandatory, but it's still recommended. And then there are others that so things like rotavirus is also optional, but then it helps to reduce the effects of rotavirus infection, which is quite common among children as well. So there are other vaccines that you can also look through the health booklet, and when you go to like the polyclinics, the doctors can also advise also.
Okay, this question is asking about cough medicine. Is cough medicine useful for under 2-year-olds? They seem to be targeted at helping children expelling the phlegm, but the 2-year-olds seem to have difficulty doing that.
Okay, so actually, most of the cough medicines are for 2 years and above. So there are very few medications that are effective for cough for less than 2 years. The only one we would say is maybe cetirizine, which is Zyrtec, that can be used in more than 6 months old, and that helps with cough that's caused by post-nasal drip. So for example, there's a lot of runny nose, and then the mucus drips backward and causes irritation of the throat. Then that can help as well. But actually, for the less than 2 years old, there are very limited medications. So some GPs or some doctors may give things like IV leaf extract or certain medications, but they may not be very effective for cough. We would say that, so some parents are also very worried, oh, there's a lot of phlegm. They want to give some phlegm medications as well. So we would actually not recommend it. Most of the time, if they can't cough out the phlegm or spit out the phlegm, they would either vomit out from coughing, or they would swallow it and it comes out in their poop, which is normal. But if we give phlegm medication, sometimes it can actually loosen the phlegm and it can cause more irritation and makes them cough even more, and that can be a bit more distressing to the child as well. So unless the child is really very disturbed by the cough, we would try not to give the cough medications.
So there's another question about how long are kids infectious for after recovering from the common cold?
So generally it's about a week. Most of the time, if they're still having symptoms like fever, severe cough, then they would be quite infectious. But most of the time, after about a week, then they would, and the symptoms are better, then they would be not infectious.
Second last question. Are probiotics useful for general health of kids?
So if let's say your child is healthy and doesn't have any medical conditions, there's no need to give probiotics. Usually we do give probiotics for certain conditions. For example, if let's say they're having diarrhea and some of the good bacteria in the gut may get lost, then you can give the probiotics to replace. Or certain conditions such as functional abdominal pain, some probiotics do play a part to help with the symptoms. But if your child is otherwise well, there's actually no real need to give the probiotics.
So that means Vitagen, not really.
But there's no harm giving, so if you want to give, it's also okay.
Okay. Okay, this is the last question. Sorry, let me see, where is it? Okay, this is not quite related to the topic that you had, but one of the questions was, is there any way to help my child prevent development of eczema? Yeah.
Okay, so eczema, there's actually a very large genetic component to it, together with the environmental component. So it would be difficult to prevent it. A lot of times we find that in children who have eczema, there's also a strong family history of other sensitivities or atopic conditions like asthma, sensitive nose, and eczema. So if you want to prevent it, it would be difficult to really prevent it. But actually, a lot of times, and eczema is a lifelong condition most of the time, you can help to control the condition, but you can't really cure it. And then you do see that children with eczema do get flares of the eczema on and off during their whole life as well. So mainly what would be useful is moisturizers. So the eczema is mainly where the skin barrier is damaged, then the skin becomes very dry because it loses a lot of water content. And then it's a vicious cycle. So it's dry, it's itchy, then the child scratches more and it damages the skin barrier even more, and that causes this vicious cycle. So what would be very useful would be putting on a lot of moisturizer, like 3 to 4 times a day, to help moisturize the skin and repair the skin barrier. Then that would help to control the eczema and hopefully prevent it from flaring up.
Any other questions from our audience? Yeah.
This question about the fiber feet, right? It's mentioned that 2 or 3% of children will have this feet. So I have 2 questions. First question is that what's the cause of it, right? And then secondly is that if a child has this, will it come back in the lifetime, constantly to have this, and whether there will be any life-threatening cause, danger to the child?
Okay, so for fever fit, it's usually within the 6 months to 6 years of age range. So mainly because the brain is still maturing, so that's why they do tend to get triggered more easily as compared to adults. So we don't really see it in adults, but more in that age range for the children. And 1/3 of the children who have 1 episode of febrile fit do tend to get a 2nd or more episodes of febrile fit. But we do see that most of the time by 6 years of age they do stop having that, and then we don't see fever fit beyond that. But if you are asking whether it causes them to have a higher chance of epilepsy, then it doesn't have. So it's the same risk as the general population, unless they come in with a little bit more atypical traits of the fever fit. Then sometimes we be more worried whether they tend to develop epilepsy later on. But in general, no. Yeah. Does that answer your question?
So sometimes this thing will go away.
Yeah, so we expect that after 6 years of age, they shouldn't get fever fit anymore. If they do get after 6 years of age, then we are also more worried, is it other things like epilepsy or other conditions?
Any other questions? If not, we thank you so much, Dr. Grace, for taking the time to deliver this talk to us. And we also have a token of appreciation to be presented by our preacher. Okay, thank you everyone. We have now come to the end of our health seminar, and we have a QR code for you to scan to give any feedback and also to make any suggestions for subsequent talks as well. Yeah. So thank you so much and have a good afternoon. Okay.